Welcome to the second part of this three-part series on harm reduction for healthcare settings. How can harm reduction be applied to achieve better health outcomes? Step 1. Build a trusting foundation in the provider-patient relationship. For any relationship to be open and effective, the first ingredient must always be trust. Stigma is an ongoing barrier to adopting harm reduction in healthcare settings and workflows, but it is also a barrier to accessing and following through with care for many individuals. This can have a significant impact on health outcomes. It's important to note that substance use disorder is not the only chronic relapse condition. Diabetes, asthma, hypertension are all conditions that require management, usually by medication or lifestyle change. If someone experiences a glycemic relapse after being diagnosed with type 2 diabetes and receiving an intervention due to their decision to resume their normal eating and lifestyle habits, they are met with care and consideration. A diabetic may be prescribed insulin and other medications and reminded to care for their feet. The same cannot be said for substance use disorder despite the similarities of the condition. Do providers talk to patients about using clean supplies or continue to prescribe buprenorphine, for instance, if they missed an appointment or failed a urine screen? The answer is usually no. The next question should be, why not? Stigma surrounding substance use has left a lasting impact on our ability to treat substance use disorder as the chronic medical condition it is, greatly limiting our ability to address the holistic health needs of the entire patient. Harm reduction approaches a patient-provider relationship with compassion, understanding, and pragmatism, free from an agenda beyond preserving life and risk. Harm reduction practitioners in syringe exchange programs serving the most difficult-to-reach injection drug users will report making many successful referrals to treatment or primary care or hepatitis C treatment, wholly due to the established trust with these outreach workers. Clients understand they have no judgment or agenda beyond keeping them alive and as safe as possible, allowing them to open the door of hope and incremental behavior change when they are ready. Step 2. Reduce harm associated with risky behaviors, lifestyle choices, or chronic conditions by applying pragmatic solutions rooted in trust. When working with patients with an active substance use disorder or a history of substance use disorder, the most immediate needs often center around prevention or treatment of conditions such as HIV, hepatitis C, sexually transmitted disease, or soft tissue infection. This is especially a concern for injection drug users, but the risk still applies for many non-injection drug users, particularly with hepatitis C. Based on the Center for Disease Control estimates, 2.4 million persons are living with active hepatitis C infection. Furthermore, despite being at increased risk for HIV and hepatitis C, a recent study published in the Journal of Infectious Diseases found that injection drug users are tested at rates far below the regular population for both viruses. Great strides have been made in treatment for hepatitis C. However, harm reduction advocates and outreach workers will report that accessing treatment for active drug users still faces barriers, such as requirements of abstinence before treatment can begin. The American Association for the Study of Liver Diseases and the Infectious Disease Society of America's Hepatitis C guidance states, in the modern direct-acting antiviral treatment era, recent or active infection drug use should not be considered a contraindication to hepatitis C treatment, and requirements for pre-treatment screening for illicit drug or alcohol use should be discontinued. The general approach to considering initiation of treatment of hepatitis C for individuals with a prior history of substance use, including injection drugs, should be the same as in patients with no history of drug use. Furthermore, it is recognized that a well-established therapeutic relationship between clinician and patient remains crucial for the optimal outcomes with direct-acting antiviral therapies for treatment of hepatitis C. Harm reduction, therefore, provides the critical platform from which to build such a therapeutic relationship with a typically hard-to-reach patient, ultimately leading to treatment access, adherence, and better overall health outcomes. Regarding HIV, while overall infection rates are declining, The Center for Disease Control reports that 1 out of 10 new HIV infections are attributed to injection drug use, male to male sexual contact, or both. Condoms are a time tested method of harm reduction, but are not utilized often enough among the most high risk populations. Pre exposure prophylaxis, or PrEP, is a highly effective tool to prevent HIV infection when condoms are not a practical choice. This is especially true when substance use is involved. Having an open, honest conversation and therapeutic relationship with patients allows them to be honest about their substance use and risk in order to receive the most effective interventions to keep them safe. If a patient feels stigmatized or ashamed of their drug use, they may not receive the care they need. For example, a patient may disclose multiple partners or risky sexual behavior and be reminded that using a condom every time is effective risk reduction. What a clinician may not know, however, is the substance use limits decision making and the likelihood of condom use. For this individual, a conversation about PrEP may be more effective intervention to reduce risk of HIV infection. That conversation can only happen, however, if the patient feels safe enough to be honest about their substance use. To learn more about applying harm reduction practices, view the next video in this series.